A brief word about who I am and how I come to this conversation. So recently, our Indigenous colleagues in McGill's Department of Family Medicine invited us to reflect on our relationship with the land, not simply as a place, but something that holds history and responsibility. That reflection has stayed with me. Wherever I've lived, I found myself drawn to the land in the early hours of the morning, running through Central Park, across the bushveld in Botswana, or finding a moment of stillness before the megacity of Dhaka began to stir. And in different ways, these encounters with the natural world have grounded me, offered calm and clarity and a sense of connection. They've reminded me that the land is not only a source of mental well-being and renewal, but also a space of connection to one another and to the natural world around us. And that sensibility has also shaped how I think about health as something rooted in social structures and relationships, to place, to community, to nature, and to the systems that build us, that hold us or fail us. Indigenous scholarship reinforces and deepens that view, reminding us that well-being is inseparable from reciprocity, responsibility, and our relationships with land and with each other. These insights matter profoundly when we ask what health systems are for and what it means for them to sustain well-being rather than merely respond to illness. So I often describe myself as a global nomad, and I've had the privilege of living and working, learning and growing in many places, from remote villages in Africa to dense urban settings all over the world, London, Boston, New York, Geneva, Dhaka, Washington, D.C. But across all these very different contexts, one thing remained constant: health inequities were everywhere. Their forms varied, but their presence did not. So you can imagine my dismay when I returned to Canada after decades away, and I realized that our so-called universal healthcare system, once a source of national pride, is siloed, sclerosed, and struggle. But what strikes me most is not only the crisis itself, but how poorly we are explaining it. We're facing a deep frontline crisis, yet we keep talking about it as if it were mainly a technical problem to be managed, a matter of staffing levels or patient flow or efficiency. And that matters because narrow ways of framing a problem tend to produce narrow solutions. So in this talk, which I have audaciously titled Fixing Primary Care in Canada, I want to share my brazenly simplistic, globally wired, social science reflections on the crisis we're in. My main claim is that fixing primary care is not simply a matter of increasing the number of providers or spending more money inside the same model. It's a whole of society challenge. It requires us to think about what primary care is actually for, how it connects to the social conditions that shape health, and what kinds of workforce infrastructure and learning we need to build. So I'm going to organize the talk into three parts. First, framing the crisis. Secondly, diagnosing root causes. And third, reimagining the system, including some suggestions for action. But before I begin, I need to offer some important caveats. First, healthcare in Canada is organized across 13 provincial and territorial jurisdictions, each with its own structures, histories, and reform trajectories. My examples will often draw from Quebec, but the broader questions I want to raise extend well beyond it, and without being too presumptuous, I feel have some relevance across the country. Secondly, fixing primary care in Canada is an enormous challenge, multi-pronged undertaking. It involves financing and payment models and regional planning, workforce strategy, service delivery, governance, digital infrastructure, stronger links with community and social services, and the capacity to implement, learn, and adapt over time. What I offer today is necessarily partial, a selective set of arguments about where I think the deeper problems lie and what they might require of us. Third, this is a rapidly evolving policy environment. New directives and reforms and local innovations are emerging all of the time. And this is encouraging. But as I will argue, meaningful change requires us to think not only within the health system, but beyond it as well. So what does a social scientist bring to this conversation about primary care? Well, a social science perspective asks us to look beyond narrow biomedical fixes and beyond simple questions of supply and demand. It asks us to examine how institutions behave, how systems are organized, how people experience them, and how power, history, and values shape what counts as care and whose needs are recognized. Health systems are socially constructed. They reflect particular assumptions, and those assumptions have consequences. So much of my career has been spent trying to understand how people seek care when formal services are weak, fragmented, impenetrable, or misaligned with what people need. Canada is, of course, a very different setting, but some lessons carry across context. When systems are poorly connected, hard to navigate, or out of step with the realities of people's lives, access suffers and needs go unmet. That is why I want to suggest a broader reading of the current primary healthcare crisis. Workforce shortages matter, but the crisis is also one of frontline organization. Weak access, poor continuity, limited coordination, and inadequate links to the community supports people need and need beyond the clinic. So, framing the crisis, what primary care is supposed to do? It is a useful question to ask to help frame my talk, but primary care is supposed to, as Barbara Starfield and colleagues have showed us in their landmark review, strong primary care improves health, lowers costs, and reduces inequities. That is a powerful reminder that primary care is not marginal at its very best. It is the foundation of an effective and equitable health system. It is where people enter the system, build relationships over time, receive care for the most common health needs, and are connected coherently to other services. Starfield's classic framework is still useful here. Primary care works well when it is first contact, continuous, comprehensive, and coordinated. Unfortunately, Canada's current crisis undermines each of these functions. First contact is compromised when people can access care only through emergency departments or walk-in encounters. Continuity weakens when family physicians retire prematurely, narrow their scope of practice, or shift towards more episodic models. Comprehensiveness is eroded by time pressures and financing structures that reward throughput over complexity. And coordination suffers in a fragmented system where referrals are poorly articulated and the waiting room becomes its own form of harm. I still find Starfield's 4 C's indispensable, but I also find it helpful to read them alongside newer work, including Bazemore and colleagues, who argue that in today's world, high-performing primary care also requires community engagement, patient-centeredness, and the capacity to respond to complexity. That extension is important because it helps name what is missing in the Canadian conversation. Access to clinicians, yes, but also stronger links between primary care, communities, and the wider systems people rely on to live well. This points to a broader vision, closer to the World Health Organization's understanding of primary health care. One concerned not only with frontline services, but also with equity, community participation, health promotion through cross-sectoral action on the social and structural determinants of health. Part of what is weakened in Canada is not only primary care capacity, but also our commitment to that larger primary health care vision. And that is why this conversation is so important. If strong primary care improves health, lowers costs, and reduces inequities, then what is at stake is much larger than access alone. And as I will argue later, we need to strengthen and extend that broader vision, one that sees primary care not just as a place to treat illness, but as a part of a broader system for supporting health, preventing harm, and creating the social and structural conditions that foster equity and well-being. So numbers matter because they tell us that the crisis we're facing is not temporary. It is deep, systemic, and sustained. Nationally, our care survey estimates that 5.9 million adults lack reliable access to a family doctor, nurse practitioner, or primary care team. High also reports that 15% of emergency department visits in Canada are for conditions that could potentially have been managed in primary care. And in Quebec, the strain is sharper still. More than a quarter of adults lack a regular healthcare provider, but provider supply is only part of the problem. Recent analysis suggests that Quebec continues to deliver some of the weakest access outcomes in Canada, despite rising physician numbers. Major public investment and repeated reforms. That points to a deeper problem in how the frontline is organized, governed, and incentivized. And those systems failures are not experienced evenly. They fall hardest on people already navigating disadvantage, older adults with complex needs, newcomers facing precarity, people living with food or housing insecurity, and populations already burdened by discrimination, disability, geography, or colonial legacies. And when primary care falters for those populations and for the system more broadly, need does not disappear. It is shifted elsewhere onto families and neighbors and communities or born alone. The labor of coordinating, accompanying, translating, waiting, and following up does not vanish. It is simply displaced and made less visible. Yet that hidden, often unpaid work is part of how the health system functions, even if policy rarely names it as such. So, what are some of the deeper choices or root causes that are behind this crisis? Well, the first one, as I see it, is that the model no longer fits the nature of need. Canada is no longer the same country, socially or demographically, that our primary care system was built to serve. We are older, more diverse, and we're living with greater complexity. And as of July 2025, 19.5% of Canadians were age 65 and over. Immigrants in the country account for approximately 23% of the population in the 2021 census, the highest proportion on record. And these shifts matter because they change what primary care has to do. An older population requires more continuity, more coordination, more follow-up, and more support across multiple services. A more diverse population requires care that's more linguistically accessible, culturally safe, and easier to navigate and better connected to settlement, social, and community supports. It also requires a frontline that can respond to more effectively to the realities facing Indigenous peoples, racialized communities, people with precarious status, and those whose encounters with the health system are shaped by discrimination, exclusion, or mistrust. So the challenge is not simply more demand, but different demand that calls for a model better organized around complexity, relationships, and connection. And demographic change is only one of dimension of the problem. The nature of need is also changing because more of what now shows up in primary care is socially driven, structurally produced, and difficult to address through clinical care alone. In Canada and in Quebec, rising social risks, financial hardship, loneliness, social isolation, food insecurity, they're showing up everywhere, especially in primary care. These pressures affect physical health, mental health, and people's ability to function day to day. From the standpoint of providers as well, there's a growing recognition that the primary care system is having to absorb problems it was never designed to solve. As one provider said to us, I know my patient's problem is social, but I don't have the time, tools, or knowledge to help. And this is not a personal failure. It is a systems problem. It tells us that the front line is carrying the consequences of social distress without the means to respond adequately. We're asking primary care to manage needs that are not only more complex, but more socially shaped and less amenable to standard clinical solutions. Oops. So the second root cause is a structural undervaluation of frontline and relational care. Primary care is consistently described as foundational. Yet in practice, it has often been underbuilt, underfunded, and expected to compensate for failures elsewhere. This matters because primary care is not simply a site of clinical care. It is where listening, explanation, coordination, and follow-through happen. It's also where the consequences of social distress, chronic illness, and systems fragmentation show up together. That kind of work takes time, team support, continuity, and a grounded understanding of local realities, the services available, the barriers people face, and the histories that shape trust and access. Yet it's precisely that slower relational integrative work that that systems so often undervalue. You can see that not only in how resources are allocated, but also in the lower status often accorded to frontline care within medical hierarchies. In Quebec, the frontline receives only 8 to 10% of the total health and social services budget, while institutional allocations continue to favor hospital structures over the front line. But the problem is not only insufficient funding, it's also that primary care is too often organized around billable volume, patient throughput, and administrative targets rather than continuity, coordination, and the relational work complex care requires. And in Quebec, where physician autonomy is a strong feature of the system, reform cannot simply be imposed from above and expected to take root in practice. So this crisis is not only one of underinvestment in frontline care, it is also a crisis of valuation. The kinds of care that hold the system together, listening, continuity, coordination, and follow through, are too often treated as secondary. And the people who provide them too often lack the status, support, and backing that they deserve. But underinvestment alone doesn't explain the shape of the crisis. We also have to ask about how reform itself has been organized. So this third route pertains more to Quebec than other provinces. Reforms to date have worked to fragment rather than integrate primary care. At least that's my argument. Over the last 15 years or so, reform in Quebec has meant centralization of the network, mergers of institutions, heavier bureaucracy, and silo-based management. Rather than strengthening integrated local care, these changes have weakened territorial coordination, devitalized local service networks, and reduced the system's ability to respond to community realities. At the same time, the medical frontline has become increasingly organized around family medicine groups, physician-led primary care clinics that have played a very important role in access, but were not built on the same territorial community accountable foundations as the CLSCs, which are Quebec's local community service center. There's also a privatization story here, which deserves mention. In Quebec, despite recent reforms, substantial public investment and rising physician numbers, access remains the weakest in the country. Fee-for-service continues to reward volume more than continuity, complexity, or collaboration. And Quebec's also seen a sharp increase in physicians opting out of public insurance regimes. That does not mean the system as a whole has become private, but it does suggest a gradual drift away from a fully public integrated frontline. Other provinces, despite their own problems, indicate different reforms are possible. Ontario, for example, is expanding interprofessional primary care teams. There's primary care action plan. British Columbia has gone further and redesigned physician payment around a longitudinal family practice, alongside wider investments in team-based community primary care. So a lot of things are happening, which is interesting. But the erosion of integrated community-anchored frontline care is not inevitable. It is a policy choice. So I will step back now from these different root causes. A model that no longer fits the nature of need, the undervaluation of frontline and relational care, and reform that's fragmented rather than supported primary care functions. And when we do that, a pattern comes into view. What we're seeing is not just a system under pressure, we're seeing a system in which something connected is missing. The problem is not only that the frontline has too few providers, it's that it lacks enough of the human and organizational layer that makes care navigable, coherent, culturally responsive, and connected to life beyond the clinic. It lacks enough of the workforce, the pathways, and the routines that help people move from the recognition of need to actual connection with useful support. So What is missing? I would argue it is this thing I call relational infrastructure, the connective tissue and health system. And by that, I mean the people and the practices, the pathways and partnerships that enable care to be accessed, coordinated, and linked across clinical, social, and community settings. So where does this idea come from? One of the most important things that I learned in Mali came from studying food insecurity and household coping. In contexts where formal systems are thin or unreliable, survival depends on systems of exchange, kinship, reciprocity, obligation, neighborliness, and small acts of kindness and redistribution. Anthropologists often describe this as the moral economy, not just an economic system, but a social one, where access to care and well-being are mediated by relationships. What struck me was that health did not begin at the clinic door. It depended on whether someone could borrow transport money, whether an aunt could care for children while a mother traveled for treatment, whether food could be shared when illness reduced labor capacity, whether someone could call on social ties in a moment of crisis. Canada's not Mali, but the lesson travels. Here too, people rely on hidden relational infrastructure to manage illness and to navigate care. And this includes family caregiving, social and community networks, and other forms of volunteer labor, translation, and accompaniment support. We often treat those as extras, but they are part of the real health system. And when we ignore them, we misunderstand both need and resilience. Relationship infrastructure, for me, is the layer that helps people be heard, guided, accompanied, followed up, and connected to the care and the supports they need. And if weak relational infrastructure is part of the diagnosis, then rebuilding it has to be part of the solution. So one way to do that is to rethink how the frontline is organized. In Quebec, we do not have to imagine this entirely from scratch. The original CLSC movement was genuinely radical. Created in the 1970s, CLSCs were local community service centers designed to integrate health services, social services, and public health within defined territories while remaining anchored in local communities. Their mandate went beyond service delivery to include citizen participation in identifying needs, shaping care, and building collective capacity. And that's what made the model so distinctive. It treated the frontline not simply as a service point, but as a public institution with responsibility for population and place. In that sense, the CLSC embodied a broader primary healthcare vision, local participation, intersectoral action, and the accountability to the conditions shaping health in a community. Unfortunately, this vision has been progressively eroded. CLSCs have become less locally rooted, citizen participation has declined, and governance has shifted towards a more centralized form of management. Quebec, in other words, has drifted away from a model of primary care as a public, community-based, and integrative infrastructure at precisely the moment when such a model may be more relevant than ever. What makes this especially interesting is that CLSCs now seem to be returning to the policy conversation. And during the last month or so, we've been hearing some references to CLSC territorial planning, funding, and affiliation, although there aren't many details available to us yet. It's not yet clear whether this signals a meaningful recovery of the CLSC's original vision or how such a revival might be reconciled with a frontline that's predominantly centered on family medicine groups. So to be continued. But for me, part of fixing primary care is recovering a vision of frontline care that is community-based, territorial grounded, and responsive to the realities of what people's lives. Once we recover that broader vision of primary care, the next question becomes practical. What kinds of roles and pathways actually make it work? My interest in and enthusiasm for community health workers grows out of decades of working in places where people's access to care depended not simply on the existence of services, but on whether someone could help people find, understand, and use those services. In Bangladesh, I studied the role and organization of community health workers in supporting maternal and child health in both rural and urban settings. Recruited from the communities they serve, these workers were trusted, embedded in everyday life, and specifically trained in health promotion, disease prevention, and referral to formal services. My research showed that their importance as relational infrastructure. In urban informal settlements in Dhaka, for example, women who identified a community health worker as part of their social network were 5 times more likely to deliver their baby with a trained birth attendant and 3 times more likely to seek postnatal care. Those experiences stayed with me. They taught me that what often determines access is not simply whether a service exists, but whether there is someone who can help people reach it, trust it, and remain connected. And that's why the idea of relational infrastructure resonates so strongly for me. Many access failures in Canada happen before and between encounters. Needs go unrecognized. Entry points are unclear or culturally misaligned. Referrals leak across handoffs, and follow-up is not sustained. Community health workers can help mitigate those failures by strengthening prevention, navigation, follow-through, and connection to community supports. What I find especially important is that community health workers are meant to complement, not replace, regulated professionals. If we take team-based care seriously, the team cannot stop at regulated clinical roles. Community health workers are part of what makes care actually work for people whose needs extend beyond the clinic. They strengthen the team internally, but they also connect it outward to households, to communities, and the wider services that shape health beyond the clinic walls. And Canada already has precedents. Community health worker type roles exist in Indigenous community health representatives, multicultural health brokers, settlement-related navigation roles, and community-based staff embedded in some interdisciplinary primary care and community health center models in Ontario and other provinces. So the problem is not lack of imagination. It's the absence of a coherent strategy to make these functions routine, stable, and scalable across the mainstream frontline, including clear role definition, team embedding, supervision, and sustained financing. So for me, implementing community health workers at scale is not an abstract workforce proposal. It is a practical response to a simple reality. When systems are fragmented and people's needs are complex, someone has to do the connective work. The question for Canada is whether we are prepared to recognize that work, organize it, and value it as a core part of primary care rather than as an afterthought. So this brings me to social prescribing. The other place where this becomes concrete is in this thing called social prescribing. And for those who are less familiar with the term, social prescribing is a way of responding when patients come to primary care with unmet social needs, such as loneliness or food insecurity or housing precarity. And social prescribing links those patients to community-based non-clinical supports. More than a referral mechanism, however, social prescribing creates a relational pathway between the health sector and the community and social sectors. In practice, the pathway usually has several steps. A provider or another trusted contact identifies the social need. A referral is then made to a link worker or navigator. That worker spends time understanding the person's circumstances, priorities, and goals, helps identify an appropriate service or activity, and works to address barriers to access, whether those are cost or transport, stigma, language, or constraints, or just the sheer complexity of the system. Then comes the part that's often forgotten, but absolutely crucial follow-up. Did the connection actually happen? Was it a good fit? What needs to be adjusted? Referrals do not work. People cannot follow through. What matters to me about social prescribing then is its wider purpose. It gives primary care one practical way of responding to the fact that many of the problems arriving in clinics are not purely organic or biomedical and cannot be resolved there alone. It is a structured means of reconnecting primary care with the supports that shape health in everyday life. Evidence on the benefits of social prescribing is still evolving, but encouraging. Its most consistent systems improvement, such as reduced clinic visits or emergency department use. And this is largely in the UK, where they've scaled social prescribing nationally. In Canada, the Canadian Institute for Social Prescribing has estimated that every dollar invested into social prescribing programs will yield $4.43 return through improved well-being and reduced health and government costs. So the promise is real, but the implementation challenges are substantial. And that is where my own work and the work of my colleagues has increasingly focused. So our dynamic team of community partners and faculty and students from McGill and Laval universities are not deterred by the challenges of implementation. Over the past 5 years or so, we've examined not only what social prescribing is, but also how it can be made feasible, equitable, and sustainable in real-world practice. Using implementation science lens, we've explored policy context, clinic workflows, community sector readiness, service user realities, and practical points of entry. We're testing light touches approaches to identifying social needs in primary care because clinicians have no time to spare. We're also building equitable governance structures that include community organizations and people with lived experience, while refining and updating our searchable inventory of community-based services called Click Social. What I value in this approach is our insistence on keeping the promise of social prescribing honest and grounded in real-world reality. Community organizations support the idea, but they have been clear that this cannot be a matter of refer and forget. It requires dignified assessment, informed matching, translation, accessibility supports, and simple processes that are sensitive to clinic workflows. It also requires accompaniment and feedback loops so that clinics and community organizations know exactly what happened. In other words, success depends not just on the existence of community resources, but on the effectiveness of the pathway between community and clinic. That lesson carries directly into the next phase of our work. Sorry, I'm still here. In the next phase of our work through ConnectQ, a collaboration among university researchers, primary care settings, and community organizations to co-develop and implement social prescribing pathways across 4 sites in Montreal. Built around community-based link workers and local governance structures, the project tests how co-design and collaboration can provide a workable foundation for this model. Our goal is to show that social prescribing can be feasible, beneficial, and scalable in the Quebec context, that primary care can be linked in practical ways to the community supports that make health and well-being possible. But making that kind of primary care real requires more than new pathways and partnerships. It also requires preparing people to value and practice it. A final part of the solution I feel very strongly about is what is which is often overlooked is pedagogy and program design that builds relational competencies. If we want a model of primary care that's more community connected and better able to respond to complexity, then we have to prepare the next generation for that work intentionally. Relational care will not emerge on its own from educational environments that continue to privilege siloed thinking and narrow technical expertise. And that conviction shaped my work in program design. When I led the creation of the McGill new undergraduate population and global health program, those values were baked in from the start. The first month is led by an Indigenous faculty who invites students to think about health differently. Less as the management of disease in individual bodies, but as something holistic, relational, collective, and inseparable from land, responsibility, reciprocity, and community. That opening is not decorative. It is meant to unsettle assumptions and reorient how students understand health, knowledge, and care. From there, the program asks students to work across disciplines, sectors, and social divides, using context as the basis for grounded learning. It aims to build reflexivity, partnership, systems thinking, interdisciplinary problem solving, and ethical community engaged practice. Our goal is to create and cultivate a different kind of thinker and practitioner, someone who recognizes navigation, trust building, and relationship making as essential work. My earlier career, helping build the Brack James C. Grant School of Public Health in Bangladesh, reinforced the same lesson about 20 years ago. It's one of the first schools of public health globally built around community-centered real-world teaching, learning, and research focused on the needs of disadvantaged communities. That experience deepened my belief that if we want different health systems, we also need different educational formations, more interdisciplinary, more experiential, more humble, and more accountable to communities. So when I say pedagogy is part of the solution, I mean that quite literally. If Canada needs forms of primary care that are more relational, more collaborative, more grounded in the realities of people's lives, then we need educational spaces that prepare the next generation to value and practice that kind of care from the outset. So where does this leave us? And I want to leave you with 3 takeaways. First, this is not just a shortage crisis. It's a crisis of fit, fragmentation, and connection. We're asking an outdated model of primary care to respond to a population that is older, more diverse, and living with greater social and clinical complexity. That mismatch is showing up everywhere, in overstretched clinicians, in patients left to navigate on their own, and in inequities that deepen when needs are where needs are greatest. So second, what is missing is relational infrastructure, the people, the pathways, practices, and partnerships that make care reachable, navigable, and responsive. When that connective layer is weak, care becomes harder to access, harder to use, and harder to trust. Third, primary care will not be fixed simply by adding more providers, opening more clinics, or pouring more resources into an unchanged model. We need to reconnect healthcare with prevention, community supports, and social care. We need to organize primary care around communities as well as clinicians and invest in the connective capacity that helps people move through care in ways that are humane, coherent, and useful. A social science perspective does not make this problem simpler. It makes it more honest. It reminds us that many of the burdens arriving in primary care originate in the social and structural determinants of health. It helps explain why the erosion of community-anchored models like the CLSC matters, why community health workers and link workers are not peripheral supports, but part of the connective capacity that we so desperately need and a stronger system requires. Why social prescribing can help rebuild links between primary care and everyday supports that make health possible, and why, if we want a different system, we also need to educate differently. So if there's one message I hope to leave you with, it is this: primary care is not only about medical access, it's about connection, connections to trusted providers, connections to community, connections to the social and structural supports that make health possible. And if we want that kind of primary care, then we have to build for it deliberately, institutionally, educationally, and financially. That in turn will require real investment in co-design, shared learning, and the social science and implementation research needed to build, refine, and adapt new models for a fuller vision of primary healthcare in Canada and Quebec, which is also my slightly self-interested way of saying, please fund and support this kind of work. Thank you very much.